Okay, welcome to Module 7. It's Greg here. So most of this module is going to be about antipsychotics, mood stabilizers, medications that we use in children for attention deficit hyperactivity disorder. But we're going to start with the first 4 or 5 slides on the autonomic nervous system. And the reason for that is so many medications can affect this system as an adverse effect, and a lot of symptoms that patients return to the hospital or to the clinic with are autonomic nervous system side effects. Remember that many drugs that we use, we haven't done many of them yet, directly impact the autonomic nervous system as well. And that's done on purpose. For example, beta blockers are a group of medications that we use to control high blood pressure and to slow down the heart rate. Well, they directly impact a part of the autonomic nervous system. So not only does the autonomic nervous system result in many adverse effects, many drugs are used to directly impact this system as well. Okay, so it'll start to make sense as we move forward with an assortment of different drugs. So basically, the autonomic nervous system is split into two divisions: the sympathetic nervous system, or the sympathetic division, and the parasympathetic division. So why do we have an autonomic nervous system? What's the purpose of it? Well, there's many functions in the body that don't need to come to your consciousness. You don't need to participate in regulating your blood pressure, in regulating your heart rate from a minute-to-minute basis. So the autonomic nervous system maintains homeostasis in the body in a variety of different organs while you can carry on with other activities through the day. And we'll see in the next slide that the two systems they cooperate with each other. It's not like one is off and one is on. They're usually on at a very low level, both of them, and one can be ramped up and increased when needed, and the other one will still be at a very low level of activity. Okay, so that'll start to make sense when we talk about it a bit more. So let's start with the two divisions. So the sympathetic division you can think of as an activating system. You suddenly need to be vigilant. You're being activated by this system that's turning on. Your heart rate is speeding up. Your blood pressure is going up. Your muscles are getting more blood flow. Your eyes, the pupils are dilating. So it's an activating system. Okay, so we call it a fight or flight system, meaning you're being activated to either face what's going on or run away from it. Okay. The other system, called the parasympathetic division of the autonomic nervous system, is the division that's more involved in the restful state. So digestion, increasing secretions in your mouth and your gastrointestinal tract, helping with urinating, so contracting the bladder, contracting the bowel to defecate. Much more involved in sexual arousal and sexual activity. And as I mentioned before, eating and digestion. So this system is often called rest and digest, uh, or feed and breed, okay, as a reminder of what some of its roles are. Okay, so let's move on to the next slide. It'll start to make more sense, but it's important that you understand that this system exists and what the main functions of each division are. So let's look at the two systems of the autonomic nervous system. And I think it's reasonable to think of them as slightly opposing each other at the beginning. It's not completely accurate to think of them that way, but I think to learn them at the beginning, it's reasonable to think them as a bit of a gas pedal and a brake. Okay, so the gas pedal is the sympathetic system that's activating the body in many different ways, and the brake would be the parasympathetic system to slow things down. Later on, we'll go into a bit more detail about that concept. So the sympathetic system leaves the nervous system at the thoracolumbar sections. So typically T1 to T12, and a bit in the lumbar region as well, that you can see in this image. Okay, and what what does this system do? So whether we're talking about the sympathetic system or the parasympathetic system, it's a two-nerve system. There's one nerve that goes to the ganglion, and in this case, it's called the sympathetic ganglion. And there's another nerve that leaves the ganglion and goes to the target organ. And in the sympathetic system, you can see that when we're talking about what it's going to affect, well, it's going to dilate the pupils. Why? So that you allow more light into your eyes because you're being activated. You need a very good vision of the environment if there's danger. It inhibits or turns down salivation. You'll have a dry mouth. Why? Because you don't need saliva currently. There's something happening in your environment where you need high focus and high attention, and that's the most important. You're being activated. It'll dilate the bronchial tubes. It'll open them up so more air is going in and out of the lungs in case you need to run. So it's trying to oxygenate you at a much higher level. Increases the heart rate, and it'll increase the contractions of each heartbeat as well. It'll shut down the gastrointestinal tract. There's no need for food at the moment. There's no need for digestion. It'll activate the liver to release glucose from glycogen in case you need a lot more energy immediately. It'll stimulate the adrenal gland to produce epinephrine, which is adrenaline, and norepinephrine, which is noradrenaline. Okay? And they will go into the bloodstream and stimulate all the receptors that I'm talking about here, again, to be activated. It'll inhibit bladder contractions, since this wouldn't be a good time to urinate, since you're in some kind of fight or flight mode. Okay? And finally, it does have a role in stimulating orgasm. The parasympathetic system has a much larger role that we'll get to in terms of sexual arousal, but the sympathetic system does have a role in orgasm, ejaculation. So it's kind of interesting that the two systems really come together in sexual activity, okay? But keep them apart a bit because really the sympathetic system is only responsible for ejaculation or orgasm. The one I wanted to add to that is that the one more area I wanted to add is that the sympathetic system also stimulates the kidney. And what does it do with the kidney? It stimulates renin secretion. And renin secretion, in the end, will increase blood pressure through the renin-angiotensin-aldosterone system. And it wants to do that to make sure that your blood pressure is good and high, to maintain blood flow to the vital organs in case you have to run or in case you have to fight. Okay, so it's really an activating system. Okay, let's go to the other side, the parasympathetic system. So this system, for the most part, is from the cranial nerves in the brain and from the pelvic region. That's where they leave the brain to have their effect on on different organs. And by far the largest nerve in the parasympathetic system is the vagus nerve. It is a huge nerve that leaves the brainstem, and you can see in this image affects many organs. There's a few other cranial nerves that have parasympathetic fibers, plus some fibers or nerves in the pelvic region. So what does this system do? Well, it's a rest digest system. So let's start at the top. Constriction of pupils. You don't need a lot of light coming in. You're resting. So it's going to constrict pupils since you're not being activated. Okay, you don't need to be fully aware and the pupils fully dilated when you're in a resting state. It's going to stimulate saliva in the mouth because you're preparing to eat. It's going to stimulate gastric juices and pancreatic juices when you do eat. It's going to constrict the pupils. It's going to narrow them a bit. Not to the point that you're wheezing, but to the point where you didn't need to have them dilated to the point that was required with the sympathetic system. It's going to slow down your heart rate. It's going to activate all the gastrointestinal system to increase peristalsis and increase secretion. And often you'll know that because, for example, when you eat a meal, what happens? Often when you eat a meal, peristalsis will be activated. And when peristalsis is activated, typically there's a need to defecate. And so there's reflexes going on where you've put more food in, and now the body is saying, okay, it's time to empty the other end and defecate. So this is all happening with the parasympathetic system. Okay, stimulating release of bile is very important, and that's with the parasympathetic system. So it's involved in constricting or stimulating the gallbladder to contract and also release bile from the liver for digestion of fats in the gastrointestinal tract. So another effect is contraction of the bladder. This is a good time to urinate. So it's going to stimulate contraction of the bladder. Okay. And don't forget, stimulate contraction of the bowel for defecation that I mentioned. And lastly, the parasympathetic system is more involved in sexual arousal, sexual activation, And really, the sympathetic system is only involved in the orgasm and the ejaculation. Okay, so the erection would be parasympathetic. The sexual arousal would be parasympathetic. So it's kind of interesting. They have a more cooperative, interactive role with that system. Okay, so we'll finish up with this slide, but when you're looking at the slide, this isn't totally complete. It's not all of the areas that the two systems innervate, but it's a good start. Okay? And remember, you can imagine if you have a medication that blocks the parasympathetic system, what it's going to do. So if I stop the pupils from being constricted, they're going to dilate. If I stop saliva flow, I'm going to have a very dry mouth. If I stop the heart from slowing down, it's going to speed up. If I inhibit or stop all the activity in the gastrointestinal tract, such as peristalsis, I'm going to get constipated. If I stop the bladder from actively contracting its muscle, I could develop urinary retention. So if you think of it as many drugs can actually block one of these systems, then you can go back and think of, oh, what did that system do initially? And if it's blocked, what's going to happen as a side effect? Okay? And we'll come to an example of that. Okay, so let's talk more about the sympathetic division, the fight or flight system that we mentioned. And really the two main neurotransmitters are norepinephrine and epinephrine. So these are released by all those nerves that you saw going to different organs. This is the neurotransmitter at the synapse, at the target organ. So whether it's the heart, the lung, the eyes, one of these neurotransmitters will be secreted by the nerve into the synapse. As well, the adrenal gland directly will secrete norepinephrine and epinephrine right into the bloodstream when it's stimulated. So not only do you have the nerves using this neurotransmitter at each individual organ that it wants to affect, but also when the adrenal glands are stimulated, these what are called catecholamines, norepinephrine and epinephrine, are throughout your bloodstream. Okay? So it's a system that is typically activated under some kind of stressful condition, or even just a perceived stressful condition. So this system can be involved in anxiety, for example, where there's perceived threat and you have anxiety, chronic anxiety, because this system is being chronically activated. Okay? So let's just say that you perceive a threat since one day while you're in your cottage in a forested area, an isolated forested area, you come across a bear in the cottage. Okay, so your body is going to immediately activate through the sympathetic system, many systems, to try and protect yourself, whether it's having to fight the bear or run from the bear. Okay, hopefully run. Bears are tough to take down. But so dilating the pupils, very important. Get a full view of what's happening in the environment. Shut down secretions in the mouth and the gastrointestinal tract. Just turn them off. Bronchodilate the lungs to get full airflow to the lungs and full oxygenation. Increase heart rate, increase contractility of the heart, which really makes each heartbeat much more forceful to maintain a very high blood pressure, for example, and to make sure that the organs that are requiring more blood flow, such as the muscles, will get them. Okay? So reduce bowel and bladder function. So turn off. There's no time to have a bowel movement. There's no time to urinate right now. So decreased activity to those organs. Vasoconstrict. So vasoconstrict the blood flow to all non-essential organs. So that's why often you'll look pale. The skin's not an essential organ. The blood flow is gonna be vasoconstricted to the skin. The gastrointestinal tract. Shut down the blood flow there. Vasoconstrict it. You don't need blood going to your gut right now. But there's some areas that you want to vasodilate, and that would be all your skeletal muscles. You want tremendous blood flow going to your skeletal muscles in case you have to fight or you have to run. So it's mainly vasoconstriction, except to the skeletal muscles where there's vasodilation. We'll talk about that later as we go into more detail about these systems. Increasing blood sugar from the liver. So glycogen is breaking down to glucose, preparing you for a good store of immediate energy, glucose, so that you can either fight or run. Okay? So if you think of it in terms of a system that's really activating you and preparing you for any potential stressor, I think you'll start to catch on about which organs are being activated and which organs are not being activated because they're not essential in the moment. Okay, so let's talk about the parasympathetic division. So we think of this as more of a rest and digest or a feed and breed system. The main neurotransmitter of this parasympathetic division is acetylcholine, meaning all those nerves you saw, going from the cranial nerves to all the different organs, or the pelvic nerves going to the bladder and the sexual organs, they all use acetylcholine as the neurotransmitter. That's going to be important to know because many drugs have anticholinergic side effects, meaning they inhibit or block this system, and it's going to result in certain side effects and symptoms. Okay, so we'll come back to that. So this system is increased or activated. Let's say activated, but I try to reserve that for the sympathetic system. So the tone of this system, the parasympathetic system, is increased, and that's going to typically be under resting conditions, less stress occurring, there's no threat to the body, and it's time to eat, for example. So the pupils can constrict. They don't need large amounts of light going in. Salivation will occur to help with digestion. The heart rate will slow down by this system. So nerves will directly go to the heart from the parasympathetic system, release acetylcholine, and slow down the heart rate. Okay? The bronchial tubes will be constricted a bit, since you don't need such huge airflow. It's going to stimulate the gastrointestinal tract to increase peristalsis, which is the contractions to move the food along the gastrointestinal tract. And also it's going to stimulate the gastric juices, pancreatic juices to be secreted, bile juices from the gallbladder to be secreted. Everything that's required for digestion is being activated. It's going to potentially stimulate bladder contractions to empty the bladder of urine. And lastly, it will have the largest role in arousal and stimulation of the sexual organs. But remember, that's where that sympathetic system comes in for ejaculation and orgasm as well. Okay? Okay, so I like this short paragraph because it's reminding you that both systems are on to a low degree all the time, and they're both involved in homeostasis, meaning maintaining normal levels of different systems in the body. So whether it's your heart rate or your blood pressure or the size of your pupil, they're all being maintained by input from the sympathetic and parasympathetic system. Okay, so if you have a bit of stimulation from both of these systems going to your heart, for example, I could make the heart beat faster by having the sympathetic system increase, or it could beat faster by the parasympathetic system being reduced. Okay? So let me give you an example. The heart is beating at 100 beats per minute. The body decides that it wants to go to 140 beats per minute. Typically, that's going to occur by increasing sympathetic tone, activating the sympathetic system, releasing norepinephrine from the sympathetic system at the heart, from nerve fibers, is going to increase the heart rate, in this example, to 140. What if a drug is used that blocks the parasympathetic system in this example? So the heart's beating at 100 beats per minute, and suddenly a drug comes into the body, and one of its effects is to block the parasympathetic system. Okay, so now the sympathetic system has more of an effect, and it didn't really even increase. It's just that the parasympathetic system was decreased. Well, that's going to result in an increased heart rate as well. Okay, so one of them can be ramped up and have its effects, or the other scenario is one of the systems can be inhibited, and the same effect will happen to the target organ, and in this case, the heart. All right. Let's use one more example. If I have increased parasympathetic tone, so I'm using a drug that increases parasympathetic activity, okay? Well, I'm going to salivate more. My body's going to release more of its gastric juices, and I'm going to have more peristalsis in my small intestine. That is an effect of the parasympathetic system, but it occurred by giving a drug. Okay? Nothing changed with the sympathetic system. The opposite is true as well. We can use drugs that stimulate the sympathetic system or inhibit the sympathetic system, and they'll have effects depending on what is used. So Let's give the example of an injection of epinephrine. So we use that for anaphylaxis. So when we inject someone with epinephrine, typically an intramuscular injection, the effects are going to be exactly the same as the sympathetic nervous system being activated. Dilated pupils, fast heart rate, bronchodilation. That's why we use it, because people come in wheezing and short of breath with anaphylaxis. It is going to inhibit the digestive tract since there's no need for it right now. It's going to increase blood pressure, okay, as part of its role in maintaining a fight or flight response. So you can see that systems can be stimulated, inhibited on either side, whether it's the sympathetic or the parasympathetic side. And going forward, you'll see that there's medications that take advantage of either stimulating or inhibiting one of these two systems as their primary role. What we're going to focus on now are the side effects of certain drugs that happen because they block parts of these systems and result in specific symptoms. Okay? Okay, so anticholinergic effects. So if it says anticholinergic, well, acetylcholine is the main neurotransmitter of the parasympathetic system. So anticholinergic is going to mean that any particular, well, the particular drug that is being used has anticholinergic side effects, and it's going to block the parasympathetic system to a certain degree. Okay? So all you need to do now is go back to that initial slide and see what did the parasympathetic system do in the first place, and if it's blocked, what's going to happen in terms of symptoms. So we're going to talk about medications that have significant anticholinergic side effects. And you're going to hear these particular symptoms. So if I block the parasympathetic system, I'm going to have a dry mouth. I'm going to have blurred vision. Why? Because my pupil is dilated. There's a lot of light coming in, and that can create blurry vision. It can also create photophobia, which is pain with bright lights. And the reason for that is because the pupil is so dilated. Okay. It can block the ability to have proper contractions of the bladder and the bowel, leading to difficulty urinating and, with the bowel, constipation. It can also lead to a slightly higher heart rate, tachycardia, because you're blocking the parasympathetic system. You're allowing the sympathetic system to have more influence. Okay, so what kind of advice can we provide someone with their anticholinergic side effects? Well, they can chew gum to try and stimulate some salivary secretions. Sipping water, keeping their mouth lubricated. Wearing sunglasses outside might be needed if their eyes are very sensitive from a dilated pupil. Maintaining a high fiber diet or maintaining adequate hydration because of the potential for constipation from these drugs. Okay? And lastly, being aware of the fact that these drugs can lead to urinary retention and difficulty urinating. So for example, someone who's on the edge with being able to urinate anyways, such as a 70-year-old man who has an enlarged prostate and was already having difficulty urinating and really emptying his bladder, is put on a medication for something completely unrelated that has anticholinergic effects, Well, that could be the final straw that stops his urinary system from being able to urinate because it has reduced contractions of the bladder muscle. Okay, so keep this in mind when we go forward, and you'll see that these side effects come up very often in many, many drugs. Okay, so it's important to understand these systems. Concentrate on the anticholinergic effects first, because many, many drugs have this particular side effect. Okay, so let's move away from that small primer on the autonomic nervous system. We'll definitely come back to that later on in pharmacology in much more detail, since so many drugs involve the autonomic nervous system. But let's move on to bipolar illness, psychosis, and what that means, medications that we use for these illnesses, and then we'll talk about some childhood mental health conditions and medications that are used there. Okay, so categories of mood disorders. We reviewed this in the previous module. They're listed here. And on the next slide, we can maybe spend a couple of minutes as a reminder of the spectrum of mood disorders. Okay, so let's just move to the next slide, keeping these in mind. Okay, major depression, bipolar, dysthymia, cyclothymia. There are mood disorders that are directly associated with the health condition that you have. So somebody who has chronic pain from severe arthritis can develop a mood disorder, typically depression from the chronic pain. Patients that are using illicit substances can develop mood disorders from either the very, very stimulant effects of the drug. They can present as someone who seems manic, or they can have depressive symptoms from certain illicit drugs. Okay, so this slide we've looked at in the previous module, just showing you the spectrum of mood disorders. Remember, anxiety is not a mood disorder. So if we look in the middle at, quote, normal mood, we have on each side of it dysthymia or elation. So dysthymia is a bit of a low mood. I think I mentioned in one of the classes that it reminds me of Eeyore in Winnie the Pooh. Just a bit of a low mood all the time, versus elation. So I'm sure you've met someone who's elated. Their mood is a bit beyond a normal mood. Okay, so that's cyclothymia, when you cycle between the two. Depressive disorder and the spectrum of severity is also listed there. Recurrent depressive disorder is very common in some patients. And bipolar illness is has much more of a spectrum to it in terms of the degree of depression that they can develop, all the way to the degree of mania that they develop, compared to, for example, cyclothymia. So bipolar illness we'll spend more time on and talk about the different drugs that are used to try and help a patient with bipolar disorder. So we're going to start with bipolar disorder. And remember, what's the main strategy for treating bipolar disorder? Well, you want to stabilize their mood so that they're not cycling between mania and depression. So there's mood stabilizers. And depending on what state they're in, for example, if they're in a depressive state, we can add antidepressants. If they're in a manic state, we sometimes need to add antipsychotics or sedatives such as benzodiazepines, because they're so agitated and hyper aroused that they sometimes need a sedative such as a benzodiazepine. Okay, so we'll move on to bipolar illness. Okay, so bipolar disorder, a bit of information on it. Once termed manic depressive, which we now use bipolar disorder. Remember, terms change over the years. We like to do that. So in the end, we have 4 or 5 or 6 different terms for the same illness. That's just what happens. It is a common mental illness that can lead to suicidal ideation or someone who completes suicide. And you can imagine that that could be in the depressive phase or in the manic phase. Okay? Taking medications and adhering to medications can be very difficult, since someone who's elated or in a manic phase doesn't necessarily want to take a medication that blocks some of those effects. So adherence is an issue. It's a condition where you cycle. You run the spectrum of mania to depressive, back to mania, over different time frames depending on the individual. So some patients can be rapid cyclers, other patients don't cycle as quickly. We don't really know the underlying cause. We think it's related to neurotransmitters in the brain. There's definitely a genetic component to bipolar disorder. So there's an inherited aspect to it. And also there's environmental factors that we think are responsible for the illness. So this slide is showing some typical symptoms of somebody suffering with bipolar disorder. So in the manic phase, increased feelings of self-esteem and grandiosity. So almost to the point where they're all powerful. They have definitely a reduced need for sleep or ingestion of food. They're highly distractible. They're often thinking of multiple things at the same time. So increased psychomotor activity, meaning they're pacing, agitated. You may hear of stories that they're telling you about definitely poor judgment, such as increased spending, taking high risk activities. They're often so elated that they're pursuing pleasurable activities, but with potentially negative consequences. So, for example, multiple sexual partners without even knowing the partners. So they're taking risks with STDs, they're taking risks with finances, and making many, many poor judgments, okay? Increased talkativeness. So they have what's called pressured speech. It's very hard to get questions in with them because they're so talkative, and they can skip from topic to topic, meaning tangential thoughts. So they might be talking about the weather in one moment and then completely change topics to talking about the carpeting in their house, and then change topics again, talking about the color of the leaves in the fall. So tangential thinking, okay, and pressured speech. And with severe mania, they can develop psychosis. And what's psychosis? Well, in order to be psychotic, you either have to have delusions that we'll get into, or hallucinations that we'll also talk about shortly. So psychosis is a very defined term that we use with delusional thinking and hallucinations, and that could happen in severe depression or uh, in severe mania. Okay, so what do you need to reach a diagnosis of bipolar disorder? Well, you need an episode of mania. Okay, so someone who has recurrent depression, we're not going to suspect bipolar disorder because they haven't gone to the other side of the spectrum. So you need to have symptoms of mania for at least a week, with showing impaired judgment and impaired functioning. And there has to be at least one episode of the mania. Okay? Hypomania is really a very watered down version of mania. It similar symptoms, but definitely not to the same level or degree or impaired functioning. So again, bipolar disorder, the etiology is really not well understood. It's likely issues with neurotransmitters in the brain. I mentioned that there's a very strong genetic component in family members. And it's also important to distinguish an episode of mania from other conditions. So illicit drug abuse can have someone present as in a manic phase, but it's from the drug. So they're not going to be diagnosed with bipolar disorder, hopefully. Schizophrenia can present with psychosis, delusions, and hallucinations. Some electrolyte disturbances can cause manic symptoms, but it's not manic because it's an electrolyte disturbance. And finally, hyperthyroidism, someone who's secreting tremendous amounts of thyroid hormone, can present with certain parts of a manic illness, but some of these are medical conditions causing the symptom. So they wouldn't be diagnosed with bipolar disorder, which is a psychiatric illness, not a symptom caused by a medical illness. Okay, so this next slide is showing you the spectrum of mania on one side and depression on the other side. So on the left are some symptoms that occur in a manic phase: the overexcitement, the restlessness, more impulsivity, poor judgment, high sex drive, potential for abusing illicit drugs and alcohol, and very poor concentration. Okay. The other side, the depressive side of the spectrum, sadness, difficulty sleeping, thoughts of suicide can occur with severe depression. Changes in appetite, such as increased or decreased appetite, can occur with depression. Lack of energy, very difficult to concentrate on any topics when you're depressed. And difficulty making decisions, even small decisions at home, can be very difficult, since it can create anxiety, even choosing what to eat that day. So severe depression is very disabling as well. So we're going to start talking about medications for bipolar disorder. It's also important to remember that patients with bipolar disorder receive significant and require significant psychotherapy. So whether it's individual psychotherapy or group counseling, it's very important for them to maintain that aspect of the therapy. They often need lifestyle changes. So maybe because of their illness, they've become addicted to illicit drugs that are difficult to withdraw from. Maybe they've become homeless because they can't hold down a steady job and they need help with housing. So there's many aspects to their lifestyle that may need assistance. You can imagine if your mood is alternating between a manic phase and a depressive phase, how difficult so many aspects of your life would be. In terms of medications, so we spoke about the fact that mood stabilizers, trying to stop these swings from mania to depression. Antipsychotics, when they're exhibiting psychotic symptoms, whether it's in the manic phase or in the depressive phase, they can have psychotic symptoms. And antidepressants are used during the depressive phase to try and improve their mood. Okay, I'm not going to go through the top part of this slide, the psychotherapy, the triggers of lack of sleep. Excessive stress can cause a manic phase or a depressive phase. ECT we've spoken about in terms of depression, so ECT can be used in the depressive phase. So pharmacologic interventions, they're very individualized to each patient. It depends on their presentation, how they cycle between mania and depression, what their requirements are for antipsychotics or antidepressants. So very individualized treatment. And remember the non-adherence issue with this illness, often in the manic phase, because the manic phase can be actually a very productive phase, not necessarily efficient, but productive in terms of how they feel and what they think they're accomplishing. Okay. Okay, so this is the drug approach to bipolar illness. So we have mood stabilizers that try and stop these swings of mania to depression, and lithium is definitely the most commonly used one in this group. Lithium is just an element on the periodic table of elements, but it's amazing what it does for bipolar illness. There's other ones that you're going to see that you'll recognize from the epilepsy group, so the anti-seizure medications such as valproic acid, carbamazepine, lamotrigine. So we'll talk a bit about those in the bipolar illness because they are also found to have mood stabilizing effects. Antipsychotics. So you'll see that there's older antipsychotics that we've used for decades, and there's newer antipsychotics that have come onto the market in the past, say, 10 to 15 years. And mainly that's occurred because of side effects from the older antipsychotics. But the new ones also have side effects, so we won't ignore that either. But they're definitely much more. They're utilized much more frequently now than the older antipsychotics. Okay. Antidepressants. Well, we spoke about the fact that SSRIs, such as fluoxetine, paroxetine, those are selective serotonin reuptake inhibitors, and Selective norepinephrine reuptake inhibitors such as venlafaxine, they're used in depression and also in the depressive phase of bipolar illness. And often we need to use anti-anxiety medications because of the agitation and increased what's called psychomotor activity, meaning the pacing, the inability to relax in a manic phase. Benzodiazepines are often added to help relax the patient. Okay, so let's start with the mood stabilizers. And as I mentioned on a previous slide, definitely lithium is going to have the most information about it. And then we'll mention the other mood stabilizers, but not to the same degree since we've spoken about them in another setting, such as epilepsy. Okay, so the main purpose of this group is to stop the cycling from mania to depression and back and forth. Okay? Okay, so let's start with a prototype medication, which is lithium. So as I mentioned before, lithium is really just an element in the periodic table. So it's really quite amazing that this element is used as a drug, and it has significant mood stabilizing effects for bipolar illness. And it also has quite a few adverse effects that we'll also get into. Okay, so it has effects in the brain that modulate neurotransmitters. I don't think going into all the details of how it modulates neurotransmitters is necessarily important. So we're going to go right to the adverse effects of someone who's taking lithium for bipolar illness. Okay, so let's review some of the adverse effects of taking lithium. So definitely gastrointestinal symptoms are a common adverse effect with lithium. So nausea, vomiting, and diarrhea can definitely occur while on lithium. These symptoms typically resolve, and they can be dealt with by taking lithium with a meal. Okay, so they're not a reason for stopping lithium. Patients who are on lithium, you'll see they'll often have a very fine tremor. So when they reach for a glass, or if they're holding a glass of water, there's a fine tremor that you'll see. And sometimes I remember having to almost want to hold the glass for them because this fine tremor, I always felt the glass was going to fall. So you'll notice that if you see someone on lithium. Sometimes we can use a medication that can reduce this fine tremor. Those are called beta blockers. We haven't spoken about them yet. They actually block the sympathetic nervous system to try and stop these tremors from occurring. But most of the time, people will tolerate the fine tremor that they have. And typically, it's really finding the lowest dose of the lithium that's required for the patient. And hopefully that also reduces the tremor. So what about the polyuria? So lithium, this tiny little element, can have an effect on the kidneys. And the effect it has is that it inhibits or reduces the effect of ADH, antidiuretic hormone. And this particular hormone reabsorbs fluid, water, from the kidney. So if it blocks this effect, you're going to have more urination, so polyuria. So this is very, very common. Okay, patients taking lithium, because of how it inhibits the effects of ADH action at the kidney, will have polyuria, and this can lead to increased thirst because they're losing more fluid. Patients on lithium often gain some weight. Okay, so there definitely is weight gain, with lithium. Two of the important adverse effects to remember as well is that lithium is a bit toxic on the kidney, and also toxic to the thyroid gland. So both of those organs are going to need monitoring. The kidney with creatinine and the thyroid gland with a thyroid hormone blood test. Okay. Goiter is a condition where the thyroid gland becomes enlarged. So why has it become enlarged potentially with taking lithium? Well, lithium blocks the production and secretion of thyroid hormone. That is detected by the pituitary gland in the brain. The pituitary gland tries to stimulate the thyroid gland more and more because it's detecting low levels of thyroid hormone. And it stimulates it so much that you get an enlarged thyroid in the brain's efforts to try and force it to make more thyroid hormone. Okay, so that's what a goiter is. It's an enlarged thyroid gland. The bradycardia and the hypotension will be with lithium toxicity, and we'll come to that a bit later. The contraindications, you'll see that lithium with pregnancy can be a bit of an issue, but also not being on lithium when you have bipolar illness can be a bigger issue. The most concerning time in pregnancy while on lithium is in the first trimester because there's teratogenic effects of lithium on the fetus. So that would be the most concerning time when a mother is taking lithium. Let's move on to nursing care, nursing considerations. So important to know the therapeutic level of lithium. So 0.6 to 1.2 milliequivalents per liter is a therapeutic level, and that's really where we want to see it when we do blood tests. Okay. Remember, when we're doing blood tests, we often take a thyroid hormone because of its effects on the thyroid gland. We'll check a creatinine level because it has nephrotoxicity effects. And we'll also check electrolytes. Why would we check electrolytes? Well, after we talk about some drug interactions, I'm going to come back to that. So lithium is an element that goes throughout the bloodstream and throughout the body, and it's very sensitive to two things: the circulating plasma volume, so how much volume you have, because if your volume is reduced, you're going to have higher levels of lithium, and that's going to lead to toxicity. Or a medication such as a non-steroidal anti-inflammatory that reduces kidney function can also lead to lithium toxicity because less lithium is being excreted. Okay, so let's talk about a couple of examples. Diuretics. So diuretics reduce circulating volume, so they drain fluid out through the kidneys as their main effect. They also drain sodium, and we're going to come back to that. So they're reducing overall plasma volume. That's going to create a potential lithium toxicity scenario. They also drain sodium out of the kidneys and into the urine. And low sodium and lithium do not get along. It creates lithium toxicity. Okay, so let me say it again. Low plasma volume, whether it's from diuretics or from severe diarrhea can lead to a severe lithium toxicity. Diuretics can also cause low sodium, and that's going to lead to lithium toxicity in the body. Okay? Non-steroidal anti-inflammatories will do it by reducing lithium excretion, leading to higher levels of lithium. Always think of non-steroidal anti-inflammatories as drugs that are going to harm the kidneys and reduce secretion or excretion of other drugs, because they do that. Okay? So let's talk about lithium toxicity a bit. So lithium toxicity is broken down based on the level in the bloodstream. Okay, so depending on whether it's below 1.5 or 1.5 to 2, above 2 to 2.5, and then greater than 2.5 is severe toxicity. And really, you're going to see a lot of neurological effects occurring as the level of lithium goes up in the blood. Okay, so and as well, you're going to see those kidney effects. So the polyuria is going to be magnified because it's inhibiting the action of ADH. Okay, so depending on what level you're at will determine what needs to be done. So if you're at a level below 1.5, well, typically those symptoms and signs will just resolve. Between 1.5 and 2, there's typically withholding of the lithium and adjustment of the medication. 2 to 2.5, you may need to remove some of the lithium from the system if someone has overdosed on lithium, such as a gastric lavage, which just means giving a liquid laxative to flush the lithium out of the gastrointestinal tract. As we go on in higher levels of lithium toxicity, so severe toxicity over 2.5, now the kidneys are not polyuric anymore. They're not producing any urine. They're oliguric, okay? And look at the central nervous system getting more and more irritable with seizures, progressing to coma and potentially death with very high lithium levels. So you can imagine that a significant overdose of lithium is very serious, even though it's just a simple element, okay? So there's a couple of things I want you to remember with lithium. Dehydration is going to cause lithium toxicity, whether it's from you running a marathon and not drinking enough and you're dehydrated, or you have severe diarrhea and you've become dehydrated. That's going to lead to lithium toxicity. If you're taking a diuretic and you become dehydrated from the diuretic, or your sodium, so hyponatremia, results from taking a diuretic, you are going to become lithium toxic. Don't forget, a low sodium and lithium do not get along, okay? Non-steroidal anti-inflammatories, a group of drugs that inhibit excretion of other drugs, including lithium, will make you lithium toxic. Okay, and what blood tests do we take routinely for someone with bipolar illness? Well, a lithium level, a creatinine level, a thyroid hormone level, and we'll also check electrolytes, okay? And namely for sodium, making sure the sodium's not too low. We'll encourage patients not to become dehydrated. We'll make sure that they're maintaining proper sodium intake so they don't become hyponatremic. and to also consider all the different scenarios where you could become dehydrated, resulting in lithium toxicity. So whether it's from a severe illness where you're not drinking anymore, or increasing levels of a diuretic that could not only dehydrate you, but lower your sodium level, will have a significant interaction with lithium. Okay? I hope that helps. Okay, so carbamazepine would definitely be considered more of an anti-epileptic or anti-seizure medication, but it's also used in bipolar illness to, again, control the cycling of the mood from mania to depression. So it stimulates the GABA system, which inhibits the brain. It relaxes the brain. And so it makes sense that it could be used to stop seizures, but also to be used in bipolar illness to stabilize the mood. So the main adverse effects of carbamazepine are going to be its effect on the brain. So increasing levels of carbamazepine are going to lead to nystagmus, which is the abnormal movements of eyes. When you look at someone and they're toxic on carbamazepine, their eyes are shifting back and forth. That's nystagmus. Double vision, vertigo, which is another term for basically room spinning. Staggering gait, so they're off balance, and these are all effects of carbamazepine on the brain and how it starts to suppress function of different brain areas. Okay, so it can be an indication actually of toxicity. So the dose may have to be checked, and we can check a carbamazepine level to see if they're toxic, if they're having a lot of these effects. Another big effect would be bone marrow suppression. So it's not common, but carbamazepine can lead to bone marrow suppression. So if we see someone with bruising, bleeding gums, anemia while they're on carbamazepine, we may suspect toxicity of the bone marrow. Okay. Remember, with any anti-seizure medication, think of rashes. So it's rashes plus other stuff. So carbamazepine is an anti-seizure medication. Those significant rashes, such as Stevens-Johnson syndrome, you always need to just think of them as a group, as the anti-seizure group, can cause serious skin rashes. Okay? So that can be a reason for having to stop carbamazepine because of a serious rash. It doesn't always have to be a very serious rash, but if you see rash as one of the concerns in a question, I think it's always a good idea to choose that one or to include it in a select all, since any of the anti-epileptic medications are notorious for causing a rash. Okay, and lastly, hepatotoxicity. We definitely check liver function test with carbamazepine because it can cause hepatitis. Okay, and what would be the symptoms of that? Yellowing of the skin or of the sclera of the eye, right upper quadrant pain, nausea, fatigue, can be signs of hepatotoxicity on carbamazepine. Okay, so that needs monitoring as well. So let's look at the nursing considerations. Well, a CBC will be done occasionally for checking the bone marrow. Liver function tests to check the liver. We can check serum carbamazepine levels to make sure that they're in the therapeutic range. advising the patient about symptoms that can occur with bone marrow suppression. So fevers, bruising, bleeding gums, anemic symptoms such as weakness, shortness of breath, dizziness. They need to return and be checked. Okay? Symptoms of hepatitis, yellowing of the skin, right upper quadrant pain, anorexic, meaning no appetite, need to be reported. Reporting severe rashes, because some of them can be that rare Stevens-Johnson syndrome. Okay? We're very careful with elderly patients with carbamazepine because of its CNS depressant effects and the risk of falling and breaking a hip or having a head injury. Okay? And lastly, carbamazepine is in that grapefruit list where it will elevate levels of carbamazepine if grapefruit juice or grapefruit is consumed. Okay, we'll have to make a whole page of the list of grapefruit juice since it seems to be a popular item. So if I'm thinking in my brain, what are the main adverse effects of carbamazepine? CNS, off balance, dizziness, potential falling. Okay, bone marrow. Okay, what about the bone marrow? Anemia, low platelets, and low white blood cell counts. Okay, and the liver, and signs of liver toxicity, such as jaundice, right upper quadrant discomfort. And lastly, with any anti-seizure medication, always think that they can cause a bad rash. Okay, so valproic acid, again, I would consider it more of an anti-seizure medication, but it has mood stabilizing properties, so can be used in bipolar illness. Look at the action, very similar. It reduces or sedates the brain through the GABA system. The adverse effects, nausea and vomiting, tend to settle down with this medication. Just like most medications, nausea and vomiting tend to settle down. There's a few that we've mentioned that it's the most prominent side effect, such as erythromycin when we were talking about antibiotics, or metronidazole is another one that really is nauseating. Valproic acid tends to settle down. The big ones here in terms of adverse effects will be its hepatotoxicity. So it can cause a hepatitis, it can cause a pancreatitis, which is deep behind the liver, the pancreas. And it can cause low platelets, thrombocytopenia. Okay, so I would concentrate more on those. We tend to monitor valproic acid levels in the bloodstream, whether you're taking it for seizures or for bipolar illness. And we do that with, we also include with that liver function tests because it can cause that hepatitis I mentioned. And sometimes we'll even check a pancreatic enzyme test, such as lipase or amylase, if someone's having abdominal pain and we suspect it may be from the valproic acid leading to a pancreatitis. Okay, so think about valproic acid as hepatotoxicity, possibly some pancreatitis, and it can lower your platelet count. Lamotrigine, again, typically used more for epilepsy and seizures. Also a mood stabilizing medication that works through the GABA system. So remember, stimulating the GABA system results in sedation and reduction of CNS excitation. So very good at controlling seizures as well. So you can see that this GABA system is really taken advantage of to suppress the nervous system. And along with that come the adverse effects, which are mainly going to be CNS. So double vision, blurry vision, dizziness, fatigue, off balance, plus always add the potential for a bad rash with these anti-seizure medications. And that's why Stevens-Johnson syndrome is listed here. Okay. Okay, so we're going to move on to psychotic disorders. And mainly we're going to be talking about schizophrenia. And the two main symptoms of having a psychotic disorder is either delusions or hallucinations. You need to have one of those or both in order to be considered psychotic. Okay, so we'll talk about those definitions next. We'll talk a bit about schizophrenia, and then we'll move on to some medications, some antipsychotics that are used to treat psychotic conditions and, of course, schizophrenia. Okay, so let's talk about characteristics of a psychosis. So what are the hallmarks of a psychosis or a patient that is psychotic? The first one is delusional thinking. So a delusion is a fixed false belief. And many delusions are of a paranoid nature. Okay, so for example, and they're not always easy to disprove, but say for example someone is having paranoid thoughts that the neighbors are surrounding his house every night until the next morning, and this repeats itself every night. So a fixed false belief about all of the neighbors surrounding his house throughout the night, and that's the delusion. So is it impossible to prove or disprove? Well, usually there's a family member or someone else that is present that is telling you that this is definitely not occurring. And usually there's a paranoid aspect to it. And it's usually a thought that is really next to impossible to be occurring. So another one would be that your wife or husband is sleeping with all the neighbors, but meanwhile you're together all evening and all night, but there's a delusion that this is happening every night. So is it impossible to prove or disprove? Not, usually again there's someone else that's saying this is impossible, but the person is very fixed on the belief. Okay? A hallucination is seeing or hearing something that's just not present. So hearing voices or commands. So command hallucinations, where you're being told to do something, which can actually be quite dangerous if they're of a paranoid nature, right? So a command hallucination that's telling a patient to go and harm someone because they're being threatened. That could be an auditory hallucination. So hearing voices is the most common, but also visual hallucinations can occur as well. Okay, so this is just a concept of psychotic illness. So what's the core of psychotic illnesses? Well, it's the hallucinations we just spoke about, the delusions, and also the thought disturbance that's occurring. So a thought disturbance is really disorganized thinking that then leads to disorganized speech. Okay, so there's abnormal thoughts, abnormal perceptions, leading to abnormal speech and communication. Okay, and that can result in agitation, bizarre behaviors, because of the underlying thought disturbance. So, schizophrenia, for example, is a very common example of hallucinations, delusions, and the underlying thought disturbance. And they often have pressured speech as well. They can have tangential thoughts, meaning thoughts that are going in one direction and then suddenly change to another direction and then change to another direction very quickly. So there's what's called a formal thought disturbance. The underlying way that someone is thinking is abnormal. Okay? And then the other symptoms around those core symptoms that can occur, so depression, anxiety, insomnia, nightmares, those aren't the core symptoms of schizophrenia, but there are other symptoms and signs that can occur due to the schizophrenia. Okay, so let's talk about positive and negative symptoms of schizophrenia or psychosis. So a positive symptom is something in addition to their condition. So delusions, well, fixed false beliefs about what's happening around you is a positive symptom. Not in a positive way, but it's a delusion is an additional symptom to the whole condition. Hallucinations is a positive symptom. So you're hallucinating about hearing paranoid thoughts about someone who, say, has died 30 years ago. So that's an auditory hallucination. That's a positive symptom because what should normally be happening is no hallucinations. So it's in addition to. Disorganized speech is positive because it's in addition to. Disorganized behavior, agitation, they're all symptoms that have been added on to the underlying condition. Negative symptoms mean you have less of something, so you have less interest. You have less ability to concentrate. You have less social interaction. You have lower emotions or lack of emotions, and you have lack of energy. So you've lost in terms of a symptom. Okay, so positive doesn't mean it's good, and so just think of it as in addition to, something's been added on top of. And definitely for psychosis, they always have positive symptoms because you have to have delusions or hallucinations in order to be psychotic. But they often have negative symptoms and positive symptoms. So just know that concept of what positive and negative mean in terms of symptoms. It's not referring to good and bad. Okay, so here's a table showing you some positive symptoms, hallucinations and delusions we've already discussed. Positive disorganization symptoms. So your disorganized speech, your disorganized thought patterns, and there's all kinds of different thought patterns. You can have, as I mentioned, tangential thinking. You can have thought blocking disorders. You can have all kinds of disorders that are in addition, so they're called positive symptoms. Okay, negative symptoms are usually all the withdrawal that can occur in schizophrenia. So um, someone who has lack of speech, alogia, very flat affect. Their appearance is very flat and very non-expressive. Very low attention span. Avolition is lack of interest in anything. So these are all negative, right? They're less than normal. They're not in addition to normal. Anhedonia is the inability to have pleasure in anything. Loss of social interest in friends. Okay, we already discussed that. So again, positive, negative symptoms of schizophrenia. Okay, this is just a slide on delusions. We already spoke about them. The idea of firm beliefs, so fixed false beliefs, we call them. They have no foundation in reality. They can often be of a religious nature or a grandiose nature. For example, I had someone yesterday who was delusional and had a very fixed belief that $200 million were being delivered to the hospital today, and that it was his money when it arrived. Okay, so a very fixed false belief. I didn't counter him. I didn't argue with him about it. They feel very strongly about their delusions, so there's no need to alter or try to change their delusion in the moment. The delusions can be paranoid. For example, they may be delusional that if they don't hold on to everything they own, someone's going to steal it. And that could be at the hospital too. So everything's stuffed in their pockets and they're hoarding everything because they think that we may steal all their belongings. Okay? And it's a positive symptom of psychosis. And in general, antipsychotic medications that we're going to talk about tend to help positive symptoms much more than negative symptoms. So the antipsychotics tend to improve the hallucinations and the delusions more than the negative symptoms of lack of interest, social isolation, lack of friends. They don't tend to improve that to the same extent. Okay, and a hallucination, another very common characteristic of psychosis. Um, so it's the perception of hearing or seeing something that isn't happening. Auditory hallucinations are typically more common in schizophrenia. Visual hallucinations can have more of an organic nature, so something more medical is happening compared to auditory hallucinations, which are more often schizophrenia or psychosis. Again, it's a positive symptom of psychosis. And the schizophrenic type disorders are definitely the most frequent disorders that we use antipsychotic medications in. Okay, we do use them in bipolar because they can become psychotic, but schizophrenia would be definitely the most common mental illness where antipsychotics are used long term. So here's a slide on the thought disorder aspect, right? So there's lack of insight and judgment. Patients often have very bizarre thought patterns, which lead to bizarre behaviors. They're very fixed on their delusions or their hallucinations, and their thinking is highly disorganized, which results in very disorganized speech patterns. Okay. Where are we going to see psychosis most commonly? Well, schizophrenia would be the most common condition where you're going to see psychotic symptoms. But remember the spectrum of bipolar. When you're severely manic, you can be psychotic. And also when you're severely depressed, you can have a psychotic break as well with reality. Again, when someone is psychotic, we often will check to make sure that they don't have any other underlying illnesses before saying that they have, say, schizophrenia or a mental illness resulting in their psychosis. So, because medical illnesses can lead to psychoses. So, whether it's brain tumors, certain medications, medical conditions, chronic alcoholism, and definitely illicit drug use can present as psychosis. So here's just some information on schizophrenia. Approximately 1% of the population suffers from schizophrenia. So you can imagine how common just schizophrenia itself is. If 1 in 100 people suffer from it, it's a high number. 3.5 million Americans, and many of which don't receive any specific treatment for their disorder. So, and again, what's the hallmark of schizophrenia? Hallucinations, delusions, and altered thought patterns. Here's the genetic link with schizophrenia. It's much greater in first-degree relatives. You can see that it's 5 to 10 times more common if you have a first-degree relative with the disorder. If you're identical twins and one develops schizophrenia, the other twin is at much higher risk of also developing schizophrenia. So there's a definite genetic component. We also think it's a neurotransmitter imbalance, in particular excessive dopamine in the nervous system. And that's why you're going to see that many of the antipsychotics block dopamine as their primary action. Some of the newer antipsychotics work slightly differently, but I would still think of schizophrenia as excessive dopamine in certain parts of the brain leading to this condition. Okay, so management of psychoses. So many of the medications that we're going to come across soon have a lot of side effects. So patients may not even trust you to take the medication to begin with. And on top of that, there's now side effects to the medication. So adherence is very difficult with someone who potentially is still having delusions or hallucinations or very disordered thought patterns. Okay, so adherence, you can imagine, can be very difficult. What's the primary goal of pharmacotherapy? Well, it's managing the symptoms, in particular, making the patient have far fewer hallucinations and delusions, and having the patient become independent and able to perform activities of daily living. Okay? So many of the medications that we use, the antipsychotics, can produce sedation. So that's not necessarily a bad thing about these medications, because often schizophrenics, when diagnosed, or patients with psychoses, have significant agitation and aggression. Okay, and sometimes we can't use the medication orally. Some are administered intramuscularly when somebody presents with acute psychoses, since they won't take the medication orally. And also, we can use long-acting intramuscular injections that last 2 weeks or a month, and then we have the patient return for their next injection if adherence to the medication is a problem. Because remember, oral medications need to be taken daily, otherwise they're not effective. So some patients that cannot adhere to daily medication use need to return to clinic for their regular intramuscular injections. Okay, so maintenance treatment, typically patients need to take this for life with schizophrenia to control the symptoms of hallucinations and delusions. So those symptoms can usually be controlled more quickly than some of the negative symptoms that I mentioned before. And the key to maintenance therapy is that you want to find the dose that controls the symptoms, but at the lowest dose, right? So the dose may have been at a much higher level to begin with, and then the dose is titrated downwards as long as the patient remains stable and without psychoses. Okay, so we're going to talk about some different drugs. I'm just showing you a slide here on different antipsychotics and just the history of them. So really one of the older ones that we're going to talk about is chlorpromazine, 1950s drug. And another one that you see there, haloperidol. In some large institutes, that might be called vitamin H, since it's used so often, or was used so often. Okay, so chlorpromazine, haloperidol are older antipsychotics. They would be called typical antipsychotics. They can still be used. They're used much less frequently because of a lot of their adverse effects they were causing for patients. And in particular, we'll talk about other adverse effects, but they were also very sedating as well. Okay. In the 80s, came up with a drug called clozapine that we'll talk about. It's still used, but it's really just reserved for resistant psychoses because it has a very nasty side effect of bone marrow suppression, and people need to have their CBC checked frequently. So it's really reserved for resistant psychoses, but there's a slide on it. And now we get into the past 20 years, where we're looking at risperidone, olanzapine, quetiapine. They're all definitely used to treat schizophrenia. Okay, and there's some other ones that you'll see in this list. Just I would view these as atypical antipsychotics. Why are they atypical? Well, they're newer. They're supposed to have less side effects compared to the older typical antipsychotics. Okay, and we'll talk about that in upcoming slides. Okay, so before we get to chlorpromazine by itself, let's just talk about any of these older first generation or what's called typical antipsychotics, right? So chlorpromazine, haloperidol are really first generation antipsychotics from the 1950s and 60s. We still use them. We actually use them more often for vomiting or to control nausea and vomiting now than anything else. But they're definitely still antipsychotics, and you'll still see patients on these. But newer generation and antipsychotics have replaced them. So they're used for psychotic disorders, schizophrenia, psychosis in bipolar disorder. And really, I would think of these as blocking dopamine receptors in the brain. And I would think of the issue with schizophrenia or a psychotic disorder as excessive dopamine in the brain. So really, these are to block dopamine receptors. Okay, another concept that I want you to remember, because it's going to make the adverse effects much easier, is when you block dopamine in the brain with a drug, you're going to increase acetylcholine levels in general. Okay? And when you do that, you get a lot of these side effects. Okay, so acute dystonia it can happen with the first dose of an antipsychotic. Rigid, tight muscles in the neck or the face, and very uncomfortable, very distressing, but easily dealt with since it occurs by the drug blocking dopamine and increasing acetylcholine. We use anticholinergics such as diphenhydramine, which is Benadryl, or another one called benztropine that you'll see in your book likely. Okay, so we just give this medication and it reverses the dystonic reaction very quickly. Because these drugs block dopamine, and Parkinson's is basically a dopamine deficiency in a part of the brain, then if you gave these drugs to someone with Parkinson's, it's definitely going to make them much worse. Okay? Because you're blocking even the remaining dopamine receptors they have left. But even in patients that don't have Parkinson's, they tend to get Parkinson's-like symptoms. So they can get a tremor, they can get muscle rigidity, they can get a shuffling gait. Those are all symptoms of Parkinson's disease. Okay? Akathisia. That's the feeling that you want to jump out of your skin. You can't keep still. You're lying there feeling that your body's moving inside when it's not. And again, that's easily treatable with an anticholinergic, such as diphenhydramine or benztropine. So we had someone on the weekend who was given some haloperidol for vomiting, for severe vomiting, secondary to THC use, marijuana use. You can get cyclical vomiting from THC. And we use haloperidol to try and stop the vomiting. And they developed akathisia. We went back in, very restless. They felt like jumping out of their skin. They were given intravenous diphenhydramine, and it settled in about 30 minutes. Okay. So the next one, tardive dyskinesia, is typically a long-term side effect of taking these drugs. And often it's not reversible. So tardive dyskinesia, so tardive means late, dyskinesia means abnormal movements, and it's typically of the face. So abnormal tongue movements, lip smacking, facial grimacing. And you may have seen someone just in the general population that has these symptoms. Unfortunately, once you start to develop these over a year or two, they don't typically go away. Sometimes a dose reduction of the medication can be attempted, or switching to a newer atypical antipsychotic can be tried. But unfortunately, often tardive dyskinesia is a permanent alteration. Okay, so the next one is neuroleptic malignant syndrome. It's very rare, but it can occur with any of the antipsychotics. Probably more commonly with the older ones, but any antipsychotic can cause this. And it's definitely a significant adverse effect by sudden blockade of the dopamine receptors in a small population, in a small percentage of the population, sorry, can lead to this syndrome of very high fevers, so 102 to 104, muscle stiffness, profuse sweating, very agitated, alterations in blood pressure and heart rate, and very fast breathing. So we have a slide on it. It's not common, but it can happen with any of the antipsychotic medications. So we're going to go over it a bit more later. Okay? And there is a treatment for it as well. So anticholinergic side effects. So a lot of these drugs that are antipsychotics have anticholinergic side effects. So let's just discuss that for a minute. Dry mouth, blurry vision, dilated pupils, constipation, potential difficulty urinating. So those are anticholinergic effects. Okay. Orthostatic hypotension is when you stand up too quickly, your blood pressure isn't maintained. And again, that's partly due to the anticholinergic effect. So because the autonomic nervous system is involved in regulating blood pressure, when you start to mess with the parasympathetic or sympathetic system, and anticholinergic definitely messes with the parasympathetic system, you can get orthostatic symptoms, orthostatic hypotension. Another anticholinergic side effect, sedation, fatigue, and that's why we often avoid anticholinergic drugs in older people. Okay? And when we're talking, so really all the ones we've spoken about in terms of adverse effects can be with any antipsychotic medication. Okay? The next one that I just want to mention is bone marrow suppression, and that's going to be more targeted towards chlorpromazine. So agranulocytosis means a drop in white blood cell count. Chlorpromazine can lead to bone marrow suppression, leading to a drop in white blood cell count. Okay, we're going to go over these effects again. As a group, all these neurological effects such as dystonia, Parkinsonism, akathisia, tardive dyskinesia, they're called extrapyramidal side effects. Okay, so EPS. We'll talk about them again. Okay, so what are the contraindications to taking this? Well, definitely if you have Parkinson's disease, you don't want to take a dopamine blocking drug, because that's the problem with Parkinson's disease, that you have low dopamine levels, right? Another effect of these drugs, by blocking dopamine, they increase prolactin in the blood. So you can see all these kind of adverse effects by, I blocked dopamine, but now I've increased something else. So any kind of cancer that's reliant or that can be stimulated by prolactin, you wouldn't use these drugs either. okay? Because it's going to increase prolactin levels by dropping dopamine levels. Anything to do with blockage in the bowel, because they have anticholinergic side effects. So paralytic ileus is just your bowel's not moving food along very well, okay? Someone who has issues with urinating, prostate enlargement, difficulty emptying their bladder, well, this has anticholinergic effects. It's going to make it worse. All right, so I'm not going to go over all of them because otherwise it just becomes totally overwhelming. We'll slowly get to them. Okay, so definitely avoiding other drugs that have anticholinergic side effects because they're going to be additive to chlorpromazine, which has a lot of sedative qualities and anticholinergic side effects. The dry mouth, the constipation, the difficulty urinating, it'll be additive. Okay. Adding CNS depressants, well, just mentioned these are sedating drugs. Okay. And as I mentioned, some of these need to be given intramuscularly because of non-adherence with the oral medications. So that's not uncommon for schizophrenics to go to clinics and receive their intramuscular antipsychotic. Okay. So you can see that the first generation antipsychotics had a lot of potential adverse effects. Okay. We went from the extrapyramidal side effects, the EPS side effects of such as dystonia, akathisia, Parkinsonism type symptoms, tardive dyskinesia, and we also went over the potential for neuroleptic malignant syndrome, which is very rare, but it's an emergency. With the use of antipsychotics, it can rarely happen. Most of them have anticholinergic side effects. They can also increase prolactin levels, and when you increase prolactin levels, it leads to potential irregular periods, and in men or women, you can get actual milk production and milk leakage from prolactin stimulation of the breasts. Okay, so we also mentioned that they can lead to low blood pressure. They can cause oversedation. Chlorpromazine, as a specific one, can lead to bone marrow suppression. So it's not surprising that newer antipsychotics came onto the market that we call atypical antipsychotics. Why do we call them atypical antipsychotics? It's probably a better idea to call them second and third generation antipsychotics as opposed to atypical, but that name has also stuck a bit as well. So before I start on this slide, I just want to mention that if someone's on an old antipsychotic, such as chlorpromazine or haloperidol, and they've been receiving it for years and they're stable on it, then there would be no reason to switch. Or, for example, someone's been going to a clinic and receiving their intramuscular first generation antipsychotic, there'd be no reason to switch. But if someone is starting on a new antipsychotic, it's going to be in this next group, the second or third generation antipsychotics. And risperidone is one of them that makes this group. Okay, so they're used for schizophrenia in psychotic episodes. They're all really quite similar. There's going to be a large list of them, so I think you need to view them as similar and just know that they're atypical antipsychotics, and risperidone is the prototype that we're going to use. So these antipsychotics block serotonin and dopamine. They're not felt to have as much EPS side effects, and that's why they became much more popular compared to the first generation antipsychotics that could definitely cause all those nasty EPS side effects. Okay, so these came onto the market and have been used much more commonly. So not only do they have fewer EPS side effects, they tend to be not as sedating as the older antipsychotics as well. So that's also a big benefit if you're not over sedating, and they don't have as much anticholinergic effects as the older antipsychotics. Okay, but now let's look at their side effects, because yes, it's true they have less EPS side effects. They tend to be a bit less sedating, true. They have less anticholinergic effects, that's true. But look at the first one, diabetes, weight gain. These can cause significant weight gain, actually leading to diabetes. Elevated cholesterol levels. So these have metabolic type side effects. Okay, that I think it's important to know. So they come with their own potential adverse effects. They can also cause orthostatic hypotension because they're still messing with neurotransmitters, and that can lead to drops in blood pressure when you get up too fast. I think I mentioned anticholinergic side effects. Yes, they can still happen, not to the same extent as the first generation. Okay? And both first generation and second or third generation antipsychotics can have sexual dysfunction. Okay? And we already spoke about the elevated prolactin levels when you block dopamine, leading to some breast discharge, some milky breast discharge in males or females, and really upsetting menstrual cycles in females. Okay? So, like other antipsychotics, these can take several weeks to take effect. And usually patients are titrated to the lowest dose that controls their symptoms and allows them to perform their activities of daily living. Okay, so think of risperidone, atypical antipsychotic, definitely in the newer generation. Okay, so just a mention of a drug. Yeah, we made it a prototype drug, clozapine. So this is really reserved for schizophrenics that are really unresponsive to other treatments because it is very effective at blocking dopamine receptors. So you're going to get all of those side effects that we spoke about. Those antipsychotic side effects for sure will come into play. But the main problem with it is its chance of causing bone marrow suppression. The leukopenia and the neutropenia and all the other cell lines that are produced in the bone marrow is a significant risk. So in order to take this drug, you really have to be cooperative in terms of coming back for regular complete blood counts to check for any bone marrow suppression. Okay, it can cause any of the other side effects that we've discussed with the first generation antipsychotics, including neuroleptic malignant syndrome, which would be very uncommon, but it can still happen. But I just want you to recognize that drug as an antipsychotic, but bone marrow suppression is the main concern with this drug. Okay, so antipsychotics, think of them as dopamine blockers in general. And when you block dopamine, you increase acetylcholine in the brain and you increase prolactin in the brain. And that can lead to different side effects. And here we're going to talk about EPS again, extrapyramidal side effects. Dystonia, that stiffness, rigidity in the face, in the neck, muscles, even in the arms or limbs. And that can happen with the first dose of an antipsychotic, especially the older ones, haloperidol or chlorpromazine. And we use benztropine, which is just an anticholinergic medication, or diphenhydramine, which has anticholinergic properties, which you're probably aware of when you take diphenhydramine. It gives you a dry mouth. It makes you tired, right? Those are anticholinergic properties. Akathisia is again, it can happen with the first dose, and it's the feeling of wanting to jump out of your own skin, and you can't keep still. You're extremely restless, and we treat that with intravenous or intramuscular anticholinergics to stop the excessive acetylcholine that's occurring. Okay, so again, diphenhydramine or benztropine can be used. Sometimes these people are so agitated, we'll give them a benzodiazepine, but really the treatment is diphenhydramine or benztropine. The Parkinson's type symptoms. Well, again, that's because you're blocking dopamine and you're increasing acetylcholine. That's what happens in Parkinson's disease. And we treat this with anticholinergics again, diphenhydramine or benztropine, to reverse these side effects. And at the top right, tardive dyskinesia, we can try and reduce the dose. We can even alter the medication to a newer generation antipsychotic. Unfortunately, tardive dyskinesia can remain permanent even when those measures are taken. So here's another slide on extrapyramidal symptoms. I call them extrapyramidal side effects, really. But so it's this balance of dopamine and acetylcholine. And when you block dopamine with antipsychotic drugs, for example, you're going to get increased acetylcholine in the brain. And that can lead to all of these extrapyramidal symptoms. So the acute dystonia. You should Google acute dystonia and look at an image. You won't forget it. The spasms of the neck and the tongue and the back can happen really with the first dose. The Parkinson's type symptoms can happen within the first few weeks. Because you're blocking that dopamine, you're going to get all the symptoms of Parkinsonism, but you don't have Parkinson's disease. So the tremor, the shuffling gait, by the way, it's a resting tremor, the drooling, the stooped posture, and the instability of standing, like you're very unstable when you stand. So that is purely from blocking dopamine and having excessive acetylcholine. Akathisia, another one that we spoke about. This can happen very quickly after the first dose. And lastly, tardive dyskinesia, more of a long-term side effect that's very hard to treat, unfortunately. And you'll see in the middle right, anticholinergics are the treatment for them. Diphenhydramine and benztropine to reverse the first three adverse effects of these antipsychotics. Not so much the tardive dyskinesia because it tends to be more permanent. Okay, so Usually we either lower the dose or we change the medication. So here's an image showing you the different signs and symptoms of someone with neuroleptic malignant syndrome. So it would be someone who's received an antipsychotic, which, as we know, blocks dopamine. And it causes significant symptoms. Luckily, this is a rare condition, but it causes significant effects in different parts of the brain. So they typically have a very high temperature. They're very agitated. They're sweaty. They have autonomic instability, meaning their blood pressure can be very high, then very low, then very high. They can have extremely fast heart rates with it. They can have muscle rigidity, tremors. When you check their reflexes, they're hyperreflexic. So a very serious condition. Luckily, it's rare, and we can treat it with a medication called dantrolene. Okay, so that's the typical treatment for neuroleptic malignant syndrome. Okay, so we're going to continue on here and discuss medications, typically stimulant medications that are used in children for attention deficit hyperactivity disorder, and some other disorders as well. In particular, autism can sometimes be treated with medications to help with some of the behaviors. Conduct disorder can also be helped with medications. I don't want you to think that medication is the answer for all of these disorders, because it isn't. They often need counseling. They often need techniques to alter and modify behavior as well. So medications are just part of the treatment for these children. So attention deficit hyperactive disorder, these children often require a very strict routine, because without it, they really have difficulty focusing and with their attention. So not only can they be hyperactive, they can have significant attention deficits as well. Okay, so you can see in this image that without a routine, very, very disorganized, very difficult to keep focused. So stimulants are used. This is a bit counterintuitive, but stimulants are used to try and help this childhood disorder. And actually, it can go on into adulthood as well. So stimulants can be used for an assortment of conditions. So ADHD is one that we just briefly spoke about. Narcolepsy is a condition that we'll just briefly talk about towards the end of this module. It's a sleep disorder that has profound daytime effects by suddenly falling asleep and having complete loss of motor control. We'll talk about that just briefly. A lot of these medications inhibit appetite, so they could be used in weight management because of their anorexic effects. So stimulants have been used for a long time to reduce appetite. Okay. Sometimes in migraine headaches, we won't talk about them too much in that setting. Okay, so here's just some presentations and symptoms of attention deficit hyperactive disorder. the inattentive aspect of it, easily distracted, unorganized, very difficult to maintain the ability to listen. The hyperactive, they don't always have to be hyperactive, which can make this hard to diagnose sometimes. But when they are hyperactive, difficulty sitting still, rushing through all kinds of tasks, and sometimes making very impulsive decisions. So often it's a combination of these symptoms. And as I said, it's not always that they're hyperactive. Okay, so what do these CNS stimulants do? Well, I'm going to tell you, years ago, before a lot of these were on the market, when a child was a bit hyperactive and difficulty focusing at school, we would give them a stimulant in the form of caffeine. We would tell the mother to consider giving them a half a cup of coffee in the morning or at noontime, because it is a CNS stimulant and it had properties that would help them focus. So that's not done so much anymore. So the aim of these CNS stimulants are really to to maintain alertness for sure, and wakefulness, but really to increase the ability to focus or concentrate. Okay. Unfortunately, they come with some physical and psychological dependency issues, and we'll discuss the adverse effects of some of them. So they're not without side effects. Okay, they can be effective, and actually sometimes we'll stop them when children aren't going to school, for example, on the weekend or summer holidays. That's called a drug holiday, since they don't need the same amount of focus and concentration. Okay, so here's some characteristics of the stimulants themselves, so the side effects. What are the big ones here? Well, definitely they can cause some agitation, loss of appetite, which is anorexia, and another big one is loss of sleep, insomnia. So are you starting to hear the stimulant side effects of these drugs? Nervousness, dizziness, increased heart rate, lack of appetite, and finally, difficulty falling asleep. So those can be significant side effects in a child or an adult. Okay, and here are some of the symptoms to familiarize yourself with in terms of attention deficit hyperactivity disorder. I won't run through all of them. I do like reviewing them, but I'm going to leave this slide to you in the interest of time so that I can keep to 2.5 hours. I think they're self-explanatory. Okay, and here's the inattention aspect of the disorder. And again, I'll leave these 9 points just for you to review, which will help you understand the condition more. And then we'll move on to the medication shortly. Okay, so this particular condition can be caused by genetics. So definitely, if you have a brother or sister or a parent with ADHD, you're more likely to acquire it. Brain injuries, so whether it's during birth or as a child, can lead to this condition. Certain toxicities, such as lead, have been linked to ADHD. Alcohol and cigarette smoking in the mother has been linked to this condition. So we know alcohol can cause fetal alcohol syndrome, and cigarette smoking can definitely lead to reduced oxygen levels while the child is developing, So often it can lead to a small child um, or a small infant at birth by heavy cigarette smoking. But here we see that it's linked to ADHD as well. Okay, and also premature birth can be associated with ADHD, which makes sense. A premature development of the brain um, at birth can be a risk factor for acquiring this disorder. Okay, so before we get into each different group, let's talk in terms of the stimulants first. Okay, so the stimulant medications, we already discussed the goals of the medications in terms of helping with the inattention, helping with the hyperactivity, but the adverse effects, which often we're also looking for, CNS stimulation, so lack of sleep, restlessness, agitation. Parents often bring back their children saying they really have a difficulty with sleeping, and that needs to be addressed because if you're not sleeping, it's really hard to concentrate the next day. And restlessness and agitation, because these really are stimulant drugs. Okay. Um, the next one is again a very common one because stimulants tend to suppress appetite. Children can lose weight, reduced growth rates. Okay, so weights are often checked at follow-up, and nutrition and their diet is discussed. So they need their height checked, they need their weight checked while on these medications. These medications are typically not taken in the late afternoon or the evening because of their effects with insomnia. So usually these medications would be taken more in the morning. Okay. There's cardiovascular effects. There's stimulants, so they can get high blood pressure, tachycardia. Okay, so similar to what we spoke about with the sympathetic nervous system. So it's not unreasonable on follow-up to get a set of vital signs to see that they're not persistently tachycardic while taking these medications or hypertensive. If taken in high enough doses, these stimulants, as mentioned when we were talking about psychosis, they could tip you over into psychosis because you can get a stimulant-induced or a drug-induced psychosis. So it is possible for that to happen. That would be unlikely though. And then finally, there is physical tolerance to these medications and a bit of a withdrawal from the stimulant. Okay, so because you're on a stimulant, when you withdraw it, you can have headaches, depression, because you've taken away the stimulant. So usually these medications are tapered and not suddenly stopped. Okay, so remember, in high doses, these stimulant medications, the top ones there, when you get to toxicity, just think of it almost like the sympathetic system is in overdrive. Dizziness, palpitations, high blood pressure, and finally, if they're extremely toxic, it can lead all the way to seizures. Okay, what about the non-stimulant? So there's a few in that group, and really the first one is an antidepressant in a way in some countries, but it's also used as a medication for ADHD. So atomoxetine, it's a blocker of norepinephrine reuptake. So it's basically a SNRI, right? So it's not a stimulant medication. And as I said, it can be used for depression in certain countries. It's used more for ADHD in the United States. So It can still cause some of the side effects, and we'll get into this drug as we go forward. There's another one called guanfacine, and we can talk about that. And lastly, there's an old drug called clonidine, which is a medication that affects a part of the sympathetic nervous system. We've really gone away from it, but it was definitely one of the first medications used for ADHD, and it was also used for high blood pressure. So it was discovered really while used as an antihypertensive that it could also be used to help children with their ADHD. Okay, so you'll hear about clonidine more in the antihypertensive category, but it's going to come up quite a bit because it's been around for so long, it has multiple indications. Unfortunately, it also has multiple bad adverse effects. Lastly, the medication in the middle there, let's call it by the brand name, Vyvanse. That is a pro-stimulant, meaning it's not the active drug. It's going to be converted into the active drug called dextroamphetamine. So it's a stimulant as well. So you can just add it to the top list, the stimulant medications, right? Because it gets converted into dextroamphetamine, which is amphetamine, of course, is a stimulant type medication. Okay, so how do CNS stimulants work for attention deficit hyperactivity disorder? So we don't really have the total answer to that. There's definitely neurotransmitters involved, but we just know through studies that it increases the attention span and alertness of the child or adult that's taking them. And if used properly, there is definitely a low chance of dependency on the drug. And for children, it can improve their symptoms significantly. And this is often in combination with other treatments. Okay, so when I say other treatments, I mean behavioral strategies that they need to apply to the classroom. So it can't just be the medication by itself. So there's CNS stimulation, which increases dopamine levels and serotonin levels, and that's felt to control some of the symptoms that these children display. Okay, remember, anorexia, lack of appetite, and significant insomnia, difficulty sleeping are the big ones. Okay, and what is that going to lead to? That can lead to irritability if they're not sleeping. That can lead to weight loss if they're not eating properly. So they definitely need advice on those two particular symptoms. Okay, so let's look at methylphenidate, which is Ritalin. Definitely a stimulant, a CNS stimulant for ADHD in particular. Can also be used for narcolepsy, but really the main indication or the most common indication would be ADHD. How does it work? Increasing norepinephrine and dopamine levels in the brain is how it works. The adverse effects we've spoken about with these stimulant medications, the insomnia, the restlessness, the reduced appetite is very important. Weight loss. And some children can't, they don't necessarily have a lot of weight to lose. So if it's a thin child that's going on to these medications, their weight has to be monitored closely. If the levels get higher, they can run into some tachycardias, fast heart rate, or what's called dysrhythmias. Same term, So dysrhythmia or arrhythmia just means abnormal heart rate, whether it's fast or slow or irregular. That's all it means. And then, of course, dependence on the medication, and then a withdrawal effect. So really, it's tapered. Since it's a stimulant, it's tapered off slowly. Okay. In terms of nursing care, this is definitely a medication you don't want to be taking later in the afternoon because of its effects on sleep. So more of a morning medication. Monitoring weight is very important, and advising on proper nutrition, since they're probably not going to be as hungry. Taking the medication with meals is important, since it can have some gastrointestinal side effects. We discussed the potential for drug holidays, say through the summer, since they don't need to be on this medication when they're not trying to concentrate at school as much. Never stopping abruptly, we've discussed. And of course, because this is a stimulant medication, you would never take this with an MAOI inhibitor or other stimulants, right? So whether they're over the counter or not. So very common medication for ADHD. Okay, I'm going to spend under a minute for this slide because it's a stimulant medication for ADHD, very similar to Ritalin, which is methylphenidate. So also promotes release of dopamine and norepinephrine, and it's going to give the same adverse effects as methylphenidate. Okay. So when would we avoid a medication, whether it's this one or methylphenidate? Well, someone with hypertension, somebody with a cardiovascular disease, somebody with hyperthyroidism, because this is going to stimulate them even more. Okay. Again, this medication is taken in the morning to try and prevent all that insomnia that children can get or adults can get with the medication. So not to take in the evening at all. And the monitoring of the weight is very important with this as well. It's just another stimulant. It's another stimulant type medication for ADHD. Okay, so let's move on to another medication, atomoxetine or Strattera. And this is really an antidepressant. So it's not a stimulant medication, and it's really indicated for ADHD. It is used in some countries for depression, since it's an SNRI, really. It blocks reuptake of norepinephrine, so you have more norepinephrine in the synapse. It can still suppress the appetite of a child or an adult. So in children, we still monitor for weight loss or growth suppression. And there you'll also see that, as with the other antidepressants, there's an initial risk of increased suicidal ideation. And lastly, along with all the other SSRIs or SNRI, like venlafaxine, there's a reduction in the threshold for seizures. So somebody who has a seizure condition, these medications can actually increase seizure activity. So we just need to monitor for that. Okay. Let's go on to nursing care next. So this medication, remember, it's an antidepressant and a medication for attention deficit hyperactivity disorder. Because this behaves as an antidepressant, you'll see that really the effects can take 4 to 6 weeks to occur for either ADHD or as an antidepressant. So really it's a matter of monitoring for common adverse effects like the appetite suppression, the weight loss, the growth suppression, and then administering the dose early in the morning to avoid any insomnia. Although again, it's not a stimulant like the the other group that we just spoke about, which tend to cause significant insomnia and significant lack of appetite. Okay, so think of this medication really for ADHD. So here's another example of a non-stimulant medication for ADHD in particular. This one has a strange action. It actually stimulates part of the sympathetic nervous system in the brain, and they're called alpha-2 receptors. Okay, and when they're stimulated, they typically cause a lot of sedation, and they can also lead to a slow heart rate and hypotension. And really it's the hypotension that makes you feel dizzy, right? So there's another one in this group called clonidine, and clonidine is another medication that's used for ADHD. Not so much anymore. It's been around for decades, and it's a bit of a dangerous medication because if taken in overdoses, you can imagine it's going to cause significant hypotension and bradycardia in a child. Okay, so we don't use clonidine anymore. You're going to come across this medication not only for ADHD, but it's a very, very old antihypertensive as well. Okay, so I won't get into the mechanism too much because you'll get more information on clonidine in this group when the autonomic nervous system is done next semester. Okay, so just know when these receptors are stimulated, okay, they can improve ADHD, but they can definitely cause sedation, low blood pressure, and bradycardia. Okay. And one last thing to mention about this. So you can imagine if you're stimulating a receptor that can lead to a slowing of the heart rate, reduction in blood pressure. If you suddenly removed it, then the results could be tachycardia and hypertension. So we tend not to stop this drug suddenly. Okay, that's just an extra point. We would definitely check a child's vital signs, blood pressure, heart rate while they're taking this medication, and also ask about symptoms of fatigue. Okay, just briefly on narcolepsy. So it's a very interesting sleep disorder where patients will suddenly have loss of muscular tone, fall asleep during the day, and have what's called cataplexy, which is again this sudden loss of muscular strength. Okay, so you can see this person having fallen asleep in his plate during the day. Unusual, wouldn't be safe while driving if you had narcolepsy. So we use stimulant medications to treat this condition, right? So we increase wakefulness and alertness with stimulants for narcolepsy. So amphetamines, methylphenidate. There's also a medication called modafinil that's for narcolepsy. So just a bit of information on it. I don't think that the expectation is to know all of the details of narcolepsy. Okay, so it seems like everybody's sleeping in their plate with this condition. Again, stimulant medications, you see at the bottom, amphetamine types of medications, or a medication called modafinil. Another interesting point about this particular medication, modafinil, or its group, is that shift workers can sometimes use this to remain alert during their shift. And also it's been used in the military for prolonged missions to maintain alertness. So in narcolepsy, also used to maintain alertness throughout the day. Okay, not an extremely common condition, just to know a bit about it.